So continue on with our discussions where we're holding motion as the central point in our network of meaning or in our semantic network. We're looking at shoulder flexion. And we're using the term shoulder flexion broadly instead of glenohumeral flexion in particular, or scapulohumeral flexion on purpose, because both can be considered. And with respect to hands-on practice, you're going to more likely than not check flexion of the shoulder as a broad motion as opposed to its subcomponent motions, unless you have a real reason to. One of the things we want to note is that a lot of what we're going to do with this particular presentation, as we did with the scapular motion presentation, is to be as straightforward as we can and not be nitty-gritty to reduce, or at least attempt to reduce, cognitive load. So we can increase cognitive load by talking about all the nitty-gritty specifics, or we can reduce it by saying these are the things that you would look at. And if you're looking at the motion problem as you identify it, especially with respect to the scapulothoracic region or the shoulder girdle as a unit, you're going to be very good at dealing with any compression or any mechanical interference with neurovascular structures here, on account of the fact that the neurovascular structures are tightly related to the region and the motions that will occur. So if you identify a problem with any of the motions, if you deal with that motion, you're going to remove any possible mechanical interference with respect to the neurovascular supply, drainage, the neurovascular bundle, however you'd like to say it. So our main objectives are to have a specific discussion of what shoulder flexion is with respect to planes and axes. And this is where we'll break a little bit of it apart. So we're talking about shoulder flexion as a broad thing, but there are smaller subcomponents to consider. General discussion of the muscles that flex the shoulder. This was pretty darn straightforward. Luckily, it's really only a portion of two muscles, or well, a portion of two muscles and a third muscle. Very general discussion of the nerves that supply the muscles that flex the shoulder, very general discussion of the vascular supply, and a general discussion of areas to assess and treat should shoulder flexion issues be suspected or reported. So our simple discussion, or our initial discussion as far as planes are concerned, the sagittal plane is a 50% cut of the body left to right. Horizontal or transverse plane, 50% of the body, 50% cut of the body top to bottom. The frontal or coronal plane is a 50% cut of the body front to back. Axes are perpendicular to the plane. So in the case of the sagittal plane, which is the motion in which flexion is going to occur, or flexion or extension going to occur, the axis is a horizontal or transverse axis as it is perpendicular to the plane. In the horizontal plane, it would be a vertical axis, or the transverse plane, vertical axis. In the frontal plane, it would be an AP or PA axis. In this case, we're talking about the sagittal plane, and we're partially talking about a clear axis as far as flexion is concerned. So flexion in the case of the shoulder would be from the anatomical position, so the palms up and arms up at the side. The arm would come up like this, right? So you have essentially glenohumeral flexion, and then you would have depression of the scapula to some degree to make up for the rest, and then you'd have some rotation of the scapula in multiple ways depending on what the patient presents. But essentially, the hands going forwards, it's like the person's reaching for the sky, but straight forwards more or less, not to the side. So you have motion like this. Shoulder extension would be essentially the complete inverse, where from the anatomical position, you can't see it on this shot, but the arm would just go straight backwards, and that would be shoulder extension, generally speaking. In this case, it's that's the motion that we're talking about. So at the glenohumeral articulation, so where the humerus joins the scapula itself, you're going to have essentially that transverse axis within the glenohumeral articulation. It is not a clear axis, as it's basically a ball and socket joint. So it's multi-axial and multiplanar, but when you have this motion occurring, it is because of the nature of the muscles or where they attach. So you more or less have a rotation like that of the humerus, or the head of the humerus in the glenoid cavity, or in relation to the glenoid cavity. Now, when you go up a little further, you're going to have some depression of the scapula. You're going to have some more or less posterior rotation of the clavicle at the SC joint as well. So this is a multi-axial and multiplanar movement, but if you understand where the movements are going to occur and the muscles that are going to impact it to some degree, and you deal with the motion itself, you're going to have pretty good success being accurate to the problem at hand. So you're going to think about the SC joint itself. You're going to think to some degree about the AC. You're going to think about the glenohumeral articulation. And you're also going to be thinking essentially about the scapula as a unit, or the shoulder girdle as a unit, because there are multiple subcomponents of the shoulder girdle that could impact shoulder flexion. So you would, as we'll discuss as we go on, you'll check it all anyways. You'll check through general areas, but with respect to the particular motion, you're primarily thinking GH and SC. The muscles, you're thinking about, or you're not necessarily thinking about, the muscles that will specifically generate shoulder flexion are going to be the clavicular head of the pectoralis major. You're going to have the anterior fibers of the deltoid and the coracobrachialis. It does not mean that no other muscles are involved when the motion gets grander, but when you're speaking more so about the GH joint, or flexion of the humerus in relation to the glenoid, you're thinking clavicular head of the pectoralis major, you're thinking the anterior fibers of the deltoid and the coracobrachialis. Now, with respect to nerves in particular, so we'll just do this really quick. The coracobrachialis is the musculocutaneous nerve. The deltoid escapes me at the moment. I believe it is the axillary. I'm probably wrong about that. But then the pectoralis major, you have the medial and lateral pectoral nerves. I believe the clavicular head is more the lateral pectoral nerve than anything else. So you've got a few nerves, but basically if you consider the neurovascular bundle and how the region functions, the shoulder girdle functions, you don't have to think about the specific nerves. You'll be okay not thinking about them, because the path of these things is so similar to any other nerve that you could deal with it effectively just by dealing with the motion. And we've shown why somewhat in the scapular discussion previously, and we'll show to some degree why here. So the neurovascular bundle, you're thinking about subclavian circulation, be it the artery or the vein. You're thinking about the brachial plexus, very generally speaking, which means that you need to think about the clavicle as a mechanical pinch point. You need to think about the axilla as a mechanical pinch point. So you're going to have to think about the scapula itself. You're going to have to think about the ribs. You're going to have to think about the muscles of the shoulder girdle, broadly speaking. You're going to have to think about the cervical region, broadly speaking, because of the brachial plexus and the anterior and middle scalenes that they pass through. You also have to think about the ribs, very generally speaking. So this is where, working on shoulders, you generally will have to check everything anyways, regardless of the particular motion problem that you have, because of how the neurovascular bundle functions here. So usually you're able to identify the particular subcomponent motion that is the most of the problem. And as long as you checked everything else, you may be able to only work on, say, shoulder flexion, if that is the particular problem. However, you are likely to find other subcomponent motions within the shoulder girdle that will require some attention. So you'll have to develop a search pattern to identify problems within that region. Now, as we talk about assessment, we have a concept that describes how to identify things in macro identified as micro. So a large motion can identify smaller subcomponent problems. But with respect to the shoulder, you're going to want to have a search pattern in there. The general search pattern is large motion, so flexion, abduction, adduction, scapular elevation, scapular depression, scapular winging, bringing it back. And then, just abduction and adduction, generally speaking, at the shoulder will allow you to assess a bunch of stuff, because you'll be able to identify where things are not functioning as they should. And in all of those motions, you're not getting a clean picture of the clavicle, so you may want to essentially pull the clavicle away from a relatively still thorax to assess that as well. So you've got to have a search pattern to check this all, because that will allow you to identify any possible mechanical impacts on the neurovascular bundle. So again, while we're talking about shoulder flexion, when we're talking about the shoulder in general, you still want to search everything. You still want to check it all. You want to check the ribs as well to identify if there could be, if you do have reason to believe that this is more on a neural or vascular side, then you still want to check all of that, because although shoulder flexion may be the motion that has a problem, you may have some other stuff going on. Then, as I already noted, you want to check the neck. So we just talk about that again to be redundant, or for the purpose of redundancy. When you're considering shoulder flexion or a problem with shoulder flexion, you still need to check the whole girdle. So you're considering the clavicle, as we already noted, the scapula, although not written there, you're considering motion of the scapula. So you're going to check the medial border, the lateral border, then you're going to check the pectoral region, generally speaking, with respect to the scapula. the cervical column, so for the neurovascular bundle, but also for the levator scapula and for the trapezius. You're going to check the thoracic column for motion there, but also for the relationship to the ribs, as well as the relationship to the rhomboids. So the rhomboids, the scapula, all the borders of the scapula, as I noticed, so the medial border, the lateral border, and then when you're considering the coracoid, you're going to consider the pectoral region. You may also have to consider the biceps. One of the heads of the biceps attached to the coracoid. So you're having to check all of these things anyway. So even if it is shoulder flexion and you're more concerned with the coracobrachialis, or you're essentially up in the high region in the biceps or on the humerus, you may be able to deal with the coracobrachialis, but you're also, just by proximity, dealing with the biceps. You're going to want to deal with the pectoral region, as we noted, if you have reason to consider a problem or identify a problem with shoulder flexion, but you're doing that for the neurovascular bundle as it passes through the axilla as well. So even though shoulder flexion is primarily determined by the clavicular head of the pectoralis major, coracobrachialis, and the anterior fibers of the deltoid, you still have to check all of this anyways because of the neurovascular bundle. You're also going to consider ribs. Now, as far as contraindications and red flags, known or suspected fractures or tears. So known fractures or tears, you don't treat. Suspected fractures or tears, generally speaking, you're almost always best served to refer out to ensure that there isn't something that you're missing prior to treating. Once it becomes a known or known fracture or tear, you don't treat that. Recent dramatic changes in cognitive functions, and this is the head or the neck, so changes in the capacity to speak clearly, slurring of speech, things of that nature, recent dramatic changes to memory. These are possible issues with blood supply in and out of the brain, or probably more so blood supply to the brain. In most cases, you don't have to differentiate. You just have to know that if there's major changes in cognitive functions, you do not treat, you refer out. Recent dramatic changes in respiration. You could have a pneumothorax. You could have something going on with the lung that is unclear, where it needs to be clear prior to engaging in any treatment, or knowing that you should not treat. It could also relate to heart issues. So if somebody tells you that all of a sudden out of nowhere, they're having a really hard time getting up a flight of stairs without losing their breath or without being very short of breath, you need some form of confirmation. So that's something to send out as well. So there could be fractures there. There could be, as I said, a pneumothorax. There could be some unknown lung issue. There could be some unknown heart issue. So those are things that you would send out. So again, as we go through this series on shoulder motion, although we'll note the particular structures that generate the motions we're talking about, we're still going to continue to over and over note that when you're dealing with any of these motions, because of the neurovascular bundle and because of how the shoulder itself works as a girdle, broadly speaking, sorry for the pop, what you're going to do is check all of them anyway. So you're going to want to develop a search strategy for the whole shoulder girdle, regardless of the particular shoulder issue you are primarily identifying and primarily dealing with.